When people hear lupus, they usually think of systemic lupus. But there are actually four types: systemic, cutaneous, drug-induced, and neonatal. Today we're focusing on cutaneous lupus. Cutaneous lupus erythematosus, also known as skin lupus, is an autoimmune inflammatory skin disease. It may occur independently, or it may occur in patients who also have systemic lupus erythematosus. A key feature across subtypes is photosensitivity, meaning ultraviolet exposure can trigger or worsen lesions. The likelihood of systemic involvement depends on the specific subtype. Cutaneous lupus is divided into three main subtypes: acute, subacute, and chronic. Chronic cutaneous lupus most commonly presents as discoid lupus. Epidemiology. Cutaneous lupus is significantly more common in women. It most commonly presents between the ages of 20 and 50. Prevalence is higher in African American, Hispanic, and Asian populations. Chronic cutaneous lupus, particularly discoid lupus, may be more common and sometimes more severe in African American patients. Risk factors. Ultraviolet light is a major trigger, and many patients experience flares after sun exposure. Cigarette smoking is associated with increased disease severity and reduced response to anti-malarial therapy such as hydroxychloroquine. Certain medications are linked specifically to subacute cutaneous lupus, so medication review is important. As with many autoimmune diseases, there is often an underlying genetic predisposition. Pathophysiology. At its core, cutaneous lupus is an autoimmune disease. The immune system becomes dysregulated and produces antibodies that target the body's own tissues. In this case, the inflammation is directed at the skin, specifically at the junction between the dermis and the epidermis. That inflammation is what causes the redness and skin lesions we see clinically. If the inflammation is persistent, especially in chronic cutaneous lupus, it can damage the skin and lead to permanent scarring. Next, we'll discuss the clinical presentation, starting with acute cutaneous lupus. This subtype most commonly presents with a malar rash, also known as the butterfly rash, involving the cheeks and the bridge of the nose. It is typically photosensitive and does not usually result in scarring. It's important to note that acute cutaneous lupus has a strong association with systemic lupus, so evaluation for systemic involvement is warranted. Subacute cutaneous lupus presents differently. It typically appears as annular, meaning ring-shaped or papulosquamous plaques, often involving sun-exposed areas such as the shoulders, upper chest, or arms. Like acute cutaneous lupus, it is strongly photosensitive and usually does not result in scarring. This subtype is commonly associated with anti-Rho, also known as SSA antibodies. In some cases, subacute cutaneous lupus may be drug-induced, so reviewing the patient's medication history is important. Chronic cutaneous lupus, most commonly discoid lupus, has a more scarring presentation. It typically presents with thick erythematous plaques and characteristic follicular plugging. Dyspigmentation is common, especially as lesions heal. Unlike the other subtypes, chronic cutaneous lupus can cause permanent scarring. If the scalp is involved, this may lead to scarring alopecia and permanent hair loss. Diagnosis is primarily clinical and based on recognizing characteristic lesion morphology and distribution. A skin biopsy may be performed if the diagnosis is uncertain. If systemic lupus is suspected, laboratory evaluation should include ANA and more specific antibodies such as anti-dsDNA, anti-Smith, and anti-RO. A complete blood count, metabolic panel, and urinalysis are useful to screen for organ involvement. It's important to remember that a positive ANA alone does not diagnose systemic lupus. Management begins with strict photoprotection, including daily sunscreen use and protective clothing. For localized disease, topical corticosteroids and topical calcineurin inhibitors are commonly used. For more extensive or persistent disease, hydroxychloroquine is considered first-line systemic therapy. Refractory or severe cases may require additional immunomodulatory therapy and referral to dermatology or rheumatology. Patient education is essential. Daily sun protection is foundational. Smoking cessation should be strongly encouraged. Medication adherence improves disease control. Patients should be monitored for systemic symptoms such as joint pain, fatigue, or signs of renal involvement. Early evaluation of scarring lesions is important to prevent permanent damage. As always, if you found this helpful, please consider subscribing to the channel for more clear, evidence-based medical education. Let us know in the comments what video you'd like us to make next.